Next up, we're going to talk about rheumatoid arthritis. Let's go into a case. A 59-year-old history professor with a history of hypertension presents with progressive fatigue and bilateral wrist pain and swelling over the past 3 to 6 months. Now, he blames his symptoms on starting amlodipine for his hypertension about 6 months ago. He reports no fevers, weight loss, or rash. His wrist pain is non-radiating, and it's a little bit more on the right side than the left side. He reports that his hands and wrist feel stiff for nearly an hour every morning, loosening up a little bit with activity. Now, he smokes a pack a day, rare alcohol use, and his uncle has psoriasis. We'll see if that's relevant later. Looking at his initial vitals, pretty unremarkable. Cardiopulmonary exam is also within normal limits. And now let's take a look at his musculoskeletal exam. So no joint deformities are present, but he has warm, boggy, swollen wrists bilaterally with mild tenderness to palpation. No other joints are affected except for a 2-centimeter, firm, non-tender, immobile nodule noted on the left Achilles tendon. Skin and nail exam are within normal limits. So let's highlight a few key features of this presentation thus far. First, it's looking like it's chronic. It's been going on for 3 to 6 months. It came on slowly, and it's just slowly progressing. We couldn't consider this to be acute. The pattern of joint involvement sounds symmetric and also oligoarticular. Remember, that means that you have between 2 to 4 joints involved, and in this case, he has both of his wrists at this point. Next up, is there evidence of joint inflammation? We've got several things supporting joint inflammation. Number 1, his wrists are boggy and swollen. Secondly, he's got some mild tenderness to palpation. And of equal importance is the fact that he's saying that he has stiffness for more than an hour every morning. All those things really support some immune-mediated process with some joint inflammation. And lastly, is there systemic involvement? A little hard to say at this point. All he's reporting is fatigue, which could be any number of different causes. But we'll hold on to that for a moment. So, let's take a look at our differential diagnosis: rheumatoid arthritis, systemic lupus erythematosus, osteoarthritis, psoriatic arthritis, and gout. Now, what's missing on this list is amlodipine, and while I'd love to indulge our patient's concern that this all started with amlodipine, I'm afraid that symmetric joint inflammation is just not a listed side effect for calcium channel blockers. For the record, amlodipine can often present with bilateral lower extremity edema, but that's not what we're dealing with here. So let's reflect on the case thus far and think about the factors for and against these 5 diagnoses on our list. Rheumatoid arthritis. Well, in support of that diagnosis is his age. It's appropriate about this time in someone's life for when RA could rear its ugly head. The presence of some systemic symptoms. Again, they're mild, but they're present. The symmetry, the fact that both wrists are involved, and the wrists themselves are the most common joint affected with rheumatoid arthritis, with some inflammation and stiffness greater than an hour. And interestingly enough, the smoking history very much favors rheumatoid arthritis. We know that smoking is both a predictor of developing RA and a predictor of disease progression and difficult with treatment. And of course, this thing going on the back of his heel, maybe that's a rheumatoid nodule, which we'll talk about more later. Against the diagnosis, however, it's actually a 3-to-1 female to male ratio, and our professor is a gentleman. And oftentimes when we think about rheumatoid arthritis, particularly on board exams, we think about a lot of classic joint deformities like Boutonniere's deformity and things like that, and we're just not seeing any of those joint deformities. But maybe we've caught the disease early. We'll leave a question mark for RA. Let's talk about lupus. Lupus, boy, that is a disease with systemic manifestations. The wrist involvement would not at all be unusual with evidence of inflammation on exam. But against it is even a stronger female-to-male divergence there. He's an elderly gentleman. Most commonly, we're talking about young black women who get lupus, not old white men. The absence of skin involvement would also steer us clear of lupus. Nonetheless, we'll leave a question mark in the box for SLA as well. Next up, let's talk about osteoarthritis. In favor of osteoarthritis is his age. Osteoarthritis is something that occurs with increasing age, And of course, it is dramatically more common than all of the autoimmune diseases combined. It's the #1 complaint in a person presenting to a primary care doctor's office with pain. It's going to end up being osteoarthritis. However, the fatigue, not a typical feature of OA. The stiffness greater than 1 hour, that is a significant ding in the idea of this being osteoarthritis. Likewise, symmetric wrist swelling. More often than not, osteoarthritis is a disease with asymmetric findings, like the right basal joint on one hand, the left knee on the other side, and maybe the right hip. You don't get the symmetry that we're seeing here. Wrist swelling, while you can certainly have an acute synovitis with osteoarthritis, it tends to be short-lived and not inflammatory and boggy the way that we're hearing in our patient. And I don't know what to make of the nodules, but that's not something we would see in osteoarthritis. So we'll keep it on the list, but we're going to have to get some inflammatory markers to see what's happening. Next up on our differential diagnosis is psoriatic arthritis. So on the one hand, in favor of it is his white race. It is more common amongst Caucasians. The family history as well, his uncle has psoriasis, that's going to support that diagnosis. And the fact that he has some systemic symptoms and this oligoarticular inflammatory arthritis, boggy wrists bilaterally. However, in contrast, the things that go against psoriatic arthritis is he has no skin or nail involvement, which would be very unusual for a patient with psoriatic arthritis to have no manifestations of psoriasis prior to the symptoms of arthritis. In addition, it's somewhat atypical joints. It's more likely to involve the DIPs rather than the MCPs or the wrist. So with that in mind, again, we'll leave a question mark, but we're not feeling so good about psoriatic arthritis. Lastly, gout. So, white, older men with hypertension. That is a very good setup for gout. He does have oligoarticular inflammatory arthritis. And that lesion, that little bump on the back of his heel, it could be a tophus. It's not a classic place for a tophaceous gout, but it could certainly be a location where you might find that. Against gout, however, the symmetry would be unusual. The chronicity, gout should really be more characterized by acute, painful flares, and we're not getting that from his story. And the morning stiffness is not a feature of gout. So, I think we're going to leave a question mark for gout as well. I'm starting to feel like we're not getting anywhere with our differential diagnosis. So let's go take a look at some diagnostic data to hopefully help us out and tease this apart. Let's take a look at some diagnostic information in hopes that this will help us with our differential diagnosis. So first up, the blood work. So the uric acid is 6.1. That's going to steer us away from acute gout, but always keep in mind that the uric acid level could be falsely low in the setting of an acute flare. Hemoglobin, it looks like we have a mild anemia, which is very nonspecific. White blood cell count of 6.4. Creatinine is 1.1. Not too helpful in the initial blood work. Let's move on to the inflammatory markers. So rheumatoid factor is not just positive, it's highly positive. Always be mindful of the fact that a number of different conditions can cause an elevated rheumatoid factor, but that is going to lean us towards rheumatoid arthritis. Much more specific finding, though, is an elevated anti-citric citrullonated peptide antibody, shown here at 84 units per milliliter. ESR being elevated at 55. Again, a lot of different things can do that, and the CRP is also elevated. Moving farther to the right, our ANA, 1 to 80. That's a very nonspecific finding. The specificity of that is nil for identifying any condition, especially in an elderly, middle-aged gentleman. And importantly, the anti-double-stranded DNA antibody is negative, which essentially is going to help us to take lupus off the differential. If somebody is having a lupus flare with active synovitis, their ANA should definitely be considerably higher, and you'd hope to have a positive anti-double-stranded DNA antibody as well. So let's talk about the radiographic findings. So looking at plain films of the hands and wrists, we can see some soft tissue swelling of the wrists, symmetric joint space loss of several MCPs, and subtle subchondral erosions of the right scaphoid and MCPs. Now, early rheumatoid arthritis could definitely be characterized by subtle subchondral erosions. So could psoriatic arthritis, however. The one thing that we wouldn't really see erosions for would be lupus, for example. Looking at all of this information combined, particularly the elevated anti-CCP and the negative findings for gout and lupus, etc., I think we can confidently say that we've got a case of rheumatoid arthritis. So let's review some additional features of this case that just highlight some other aspects of treatment and care for rheumatoid arthritis patients. First off, his history of hypertension is important for a number of reasons. Keep in mind that patients with rheumatoid arthritis have a chronic inflammatory state going on. While we would always counsel a patient about cardiovascular risk if they have hypertension and he smokes a pack a day, rheumatoid arthritis is going to raise the stakes even further. All that chronic systemic inflammation is a major cardiovascular risk factor by virtue of progressive damage to your entire circulation and your endothelial cells on all your vessels. So something that he should be mindful of and hopefully will be ammunition to help encourage him to quit smoking. And lastly, on the topic of smoking, while I mentioned this before, rheumatoid arthritis is considered an idiopathic disease, there is really strong evidence that smoking itself is an independent risk factor for rheumatoid arthritis. So not only does it predict disease, but it also predicts disease progression. It's going to be a lot harder to treat his rheumatoid arthritis as long as he's smoking. So he's got some really good reasons to quit smoking. As further indication of the systemic inflammatory nature of rheumatoid arthritis, as many as 2/3 of patients with newly diagnosed RA will have antecedent systemic symptoms before arthritis even develops. Now, this might include just general fatigue, malaise, etc., as an R patient, or it might involve weight loss, generalized weakness, or even subjective fevers. Now, family history is crucial to taking a history in patients with joint inflammation. Now, our professor did not end up having psoriatic arthritis, but a family history of any kind of autoimmune disease nearly always increases your risk of your patient having some other sort of autoimmune disease. Now, the most common genetic association with RA is the HLA-DR4 allele, which is also, coincidentally, one of many alleles associated with psoriasis. So I suspect the uncle having psoriasis is still related to our patient's development of rheumatoid arthritis. Next up, I sort of mentioned this a little bit before, but don't be led astray by the absence of joint deformity, even though you're accustomed to seeing pictures of joint deformity if you look in any textbook on rheumatoid arthritis. Oftentimes we're thinking about really advanced changes like Boutonniere's deformities and swan neck deformities, ulnar deviation, etc. But the findings in our gentleman with less than 6 months of symptoms are going to be much more subtle, and the radiographic findings are going to be much more subtle. And with advances in diagnosis and treatment, we're going to just see a lot less of those advanced changes than might have been present historically. So just keep that in mind. The most common joints, speaking of joints, that you're going to see in rheumatoid arthritis are circled in red on this plain film here and on this centuries-old drawing by Vesalius. See how we're highlighting the MCPs in that radiographic picture, as well as the PIPs, the proximal interphalangeal joints, and the wrist joints. In contrast, DIPs should not be involved. You'd be more thinking about psoriatic arthritis or even hemochromatosis with DIP involvement. In addition to those most common presenting joints that we've mentioned in the X-ray on the left, there are a number of other joints which are commonly involved with patients with rheumatoid arthritis with advanced disease progression. These would include the elbows, the shoulders, the knees, and rarely we can oftentimes see atlantoaxial subluxation, which is where the C1 and C2 vertebrae are no longer articulating correctly and can even lead patients to have acute spinal stenosis issues. When they twist their head to the left or to the right, you can actually pinch the spinal cord. So that's a potentially devastating manifestation of late, uncontrolled rheumatoid arthritis. Thank you, Vesalius. Lastly, this finding down here of an immobile nodule. This is suggested of a rheumatoid nodule, which is a painless subcutaneous growth which can be up to several centimeters in size, often found on extensor surfaces at pressure points like the olecranon process, the Achilles tendon, maybe the forearm, and some other sites. Now, they are in themselves completely benign, though they may be associated with more severe rheumatoid arthritis disease. And of note, they can also appear on viscera, like in the lungs or even on the vocal cords, so something to be mindful of if you find something on deeper imaging. Looking at the blood work, as I mentioned, a normocytic anemia is the most common hematologic abnormality in RA, but completely nonspecific. We should probably talk briefly about this rheumatoid factor thing, so make sure we understand what that actually means. So, what is rheumatoid factor? Now, we know that rheumatoid arthritis is an idiopathic condition, but we do know that it is a T-cell mediated autoimmune disease. So whatever it is that got those T cells revved up, they ultimately start to stimulate B cells. And once the B cells get going, they are producing IgM. Remember that IgM antibodies form these pentamers, shown here on the right. And rheumatoid factor, which is an IgM antibody, has a predilection for the Fc portion of another IgG antibody. Now, the detection of rheumatoid factor in the serum is about 80% sensitive for rheumatoid arthritis, so it's going to miss some cases of rheumatoid arthritis, and those, by the way, are called seronegative rheumatoid arthritis. But it's also a fairly reliable marker of disease activity. So the higher the rheumatoid factor level, the more likely this person has active inflammatory disease. Rheumatoid factor can also be positive in some other conditions, particularly cryoglobulinemia, Sjogren's, mixed connective tissue disease, amongst a variety of others. Now, the aforementioned anti-citric citrullinated peptide antibody, in contrast, is highly specific for rheumatoid arthritis. In fact, greater than 95% specific. So it's a much better rule-in test than rheumatoid factor. Now that we've made our diagnosis and we've talked about a few of the pathophysiological principles, let's move on to talk about treatment. NSAIDs are very good and very useful for the acute flare. Again, they are anti-inflammatory drugs, so they're useful for the short term. You always have to be careful of a person's kidneys and their GI tract, but otherwise, if there's no other contraindications, getting started with ibuprofen or another NSAID is a good way to start. Shown here is all of the disease-modifying anti-rheumatic drugs, and this includes methotrexate, leflunomide, sulfasalazine, hydroxychloroquine, and one last one not shown here is azathioprine. And these are our biologic disease-modifying anti-rheumatic drugs. They include TNF-alpha antagonists like infliximab, etanercept, adalimumab. Then we have our interleukin-1 antagonists, the most well-known one being anakinra, and then some anti-B cell antibodies as well, like rituximab. There's a variety of other medications out there as well, and it seems like there's new medications coming out all the time. Importantly, the ones in the biologics category are actually really expensive, and they're oftentimes injectables, whereas our non-biologic ones are very inexpensive for the most part. They've been around a long time, and many of them are oral. A study shown back in 2013 found that the cheap drugs, a triple therapy with methotrexate, sulfasalazine, and hydroxychloroquine, was actually more effective than an expensive drug like etanercept with methotrexate, which really changed the game in terms of us thinking about how to best manage this disease. All right, it's time for us to do a few quick review questions. Remember, I'm going to ask a question. Feel free to pause the screen and come up with your own answer, and then we'll review the answer. Which of the following is not a classic feature of rheumatoid arthritis? All right, well, one of the classic features of RA is symmetric joint involvement, so that's going to stay there. Stiffness greater than 30 minutes, you should always look for that when you're thinking about an inflammatory rheumatologic disease. Primarily affecting large joints, it does affect large joints, but I wouldn't have used the word primarily. And radiography reveals erosive changes. Well, that's definitely true. So number 3 has got to be the right answer because it's not true. More commonly, we're talking about smaller joints, like the PIPs, the MCPs, and certainly potentially the wrists. Okay, next question. Rheumatoid nodules are painful to the touch. Wrong. They're non-painful to the touch, so that's definitely not correct. Rheumatoid nodules are most commonly found at the hips and shoulders. That's also false. We know that rheumatoid nodules are much more commonly found at the olecranon, at the Achilles tendon, maybe in the forearm, but not the hips and shoulders. Next up, rheumatoid nodules can appear in visceral organs such as the lungs. Well, that's definitely true. That would be the most common place to find a visceral rheumatoid nodule would be in the periphery of the lungs. And lastly, rheumatoid nodules are often pre-malignant lesions, and that's definitely false as well. They're totally benign, and you can reassure patients not to worry about them. So our answer is clearly number 3. Okay, one last question. Which of the following is true of rheumatoid arthritis? Okay, anti-double-stranded DNA antibodies are highly specific for rheumatoid arthritis. Now, I'm hoping that you're thinking anti-DS DNA antibodies are associated with lupus, not rheumatoid arthritis. So that one's off the list. Number 2, anti-CCP is highly specific and highly sensitive for rheumatoid arthritis. And that's true. That's why we use that test. The sensitivity is in the 80s, but nonetheless, I'd consider that to be highly sensitive. Third, anemia is a rare finding. Actually, it's the most common hematologic finding in RA. And lastly, ESR and CRP are typically low normal. Now, that's not true either, especially if somebody's having acute synovitis with some inflammation and symptoms. You expect their ESR and CRP to be modestly elevated. So our answer is definitely number 2. And with that, I think we're done talking about RA.